I'm really happy to be here talking to you about high blood pressure tonight. This is a really critically important topic. I hope you leave after this evening's talk with 3 or 4 new bits of information that you can actually put into practice for yourself. That is our goal. I want to start by assuming that you are all sitting comfortably with your feet flat on the floor, with your back resting comfortably against a chair. There's likely a blood pressure cuff either on your arm already or beside you, ready to go. And I just want you to sit back and relax and enjoy this session. I am a practicing family physician, and the idea of clinical practice guidelines can be overwhelming. There are literally hundreds of guidelines that family doctors need to at least be somewhat comfortable with and familiar with. There are none that I need to use day in and day out as much as I do the hypertension guidelines. And the set that I'm presenting to you tonight was published in the CMAJ, the Canadian Medical Association Journal, in 2025, May of 2025. So we've been using these guidelines and these targets, or we should have been, for a good part of the last year because this is where the best evidence has been. So we're going to dive right into a case. This is Maria. Now, like many of us, I hope tonight, Maria is feeling pretty good right now. She stopped by a pharmacy today, decided to put her arm in a blood pressure machine, and as you can see, the automated blood pressure reading came out as a reading of 140/95. Now, if some of you are actually taking your blood pressure right now while we're doing this session, just stop. Just stop and try and absorb as much information as you can. The goal of the talk is to make you feel better about your health through knowledge and not to scare you into action tonight. So if you are getting high readings, throughout your week, throughout your day, you're going to learn all the skills that you need tonight to be able to manage those as best you can. So Maria doesn't feel any different with this reading. She has no symptoms. She didn't feel any different than she did 10 minutes ago. But this number has put her at the start of a very important journey. Today, we're going to follow Maria through to see exactly how she and you can navigate these new guidelines that I've been talking about. And although this talk focuses on hypertension and its clinical practice guidelines, I really want to emphasize that my work as a family physician has consistently been and must consistently be grounded in a whole person approach. So we need to factor in an individual's values, principles, preferences for treatment. We don't just blindly apply guidelines, but they do offer us an excellent framework for best understanding how to help people in society. So, what is hypertension? Let's start with a definition. This is the medical term for high blood pressure. It means that the blood flowing against your artery walls stays too high over time. And because most people feel completely normal, unless they're going in to get it checked properly or checking at home, they actually don't know that there is a problem. So, my question really is a rhetorical one. Is hypertension a disease or is it a risk factor? The answer is it is both. It is a disease in its own right, and it is also the number one risk factor for many other conditions that collectively account for more deaths worldwide than any other conditions. And the diseases I'm talking about are ischemic heart disease, strokes, peripheral vascular disease, chronic kidney disease, and dementia. Hypertension is the number one risk factor, modifiable risk factor for all of those conditions. This really should make you think about the old adage in medicine, you are only as healthy as your blood vessels. There is a lot of truth to that. And diseases that injure the inside of blood vessels account for more deaths worldwide than any other conditions. And yet you'll never find hypertension listed as a cause of death on a death certificate. You also won't see it listed on the top 10 causes of death worldwide or in Canada, but as a single disease and as a single risk factor, it causes more and contributes to more deaths than any other worldwide, over 10 million per year. This condition is a big deal. And just to step back and think about this another way, if all those diseases I just mentioned, ischemic heart disease, stroke, dementia, peripheral vascular disease, chronic kidney disease, if they all decided to hop on the same bus and go for a ride, hypertension is the disease driving that bus. So Let's see what the context and landscape is in Canada. There are an awful lot of people in Canada with high blood pressure. 8.2 million adults is the most recent estimate. That is approximately 25% of the adult population. As I mentioned, it's a leading chronic disease. It's one of the most common chronic conditions that we deal with. And high blood pressure is often a silent and major driver of preventable heart, brain, and kidney diseases. It literally impacts everything. How are we doing in Canada? So this slide is meant to represent a little bit of a report card for us. So we actually do very well. Compared to almost every country in the world, Canada does a good job of not just writing clinical practice guidelines, but promoting them and disseminating the information to the public, which is part of what our goal is here tonight. To let you understand what the best evidence is, so that if you are one of those individuals with high blood pressure, you've got the best chance of being in the controlled category. So this picture is looking at 100 people that already have high blood pressure. In Canada, of every 100 people that have high blood pressure, 65 have it well controlled. Many other countries around the world are struggling to get to 20 or 30%. Canada is doing reasonably well, but there is room for significant improvement. Those yellow faces are diagnosed but not controlled. So these are people that know they have high blood pressure, but for a variety of reasons, some of which we'll talk about tonight, they don't quite have the targets met for managing their blood pressure and keeping their risk as low as possible. Now, you don't want to be the gray face here, right? These are individuals that have high blood pressure that don't yet know it. So if you haven't seen your doctor in a while, if you have a blood pressure machine and haven't checked it in a while, check and see where you're at. And if you're above the targets that I'm going to share with you tonight from the new clinical practice guidelines, make an appointment with your doctor and get things checked out because there is treatment and an abundant amount of help available. So why does high blood pressure happen? So, there is a normal aging process where we lose elasticity in our blood vessels. That is the price of doing business. That is reality. The arteries become stiffer, but you can have healthy vascular aging without it causing high blood pressure or without your blood pressure being affected in a way that gets you above the targets. But hypertension, when you do have high blood pressure, is accelerating all those impacts of aging. It's accelerating the loss of elasticity. It's accelerating the arterial stiffening, and it becomes a full circle where that is now worsening your blood pressure further. We have to focus, and we're going to focus a lot tonight on preventable risk factors, ways that we can manage our lifestyle to improve our blood pressure before we have to hit other more advanced treatments, which are also going to be an important part of what we're going to talk about tonight. So here's the thing. The most common myth that I see in my patients around blood pressure is that they believe they're having symptoms from their blood pressure. Now, that can be the case in extreme circumstances. If you have what we call a hypertensive urgency or emergency, where your blood pressures systolic are exceeding 200 and you have a headache or vision changes or flushing, in that situation, you need to get to an emergency department. No question. But most garden variety people, essential hypertension related to aging, blood pressures that are in the range of 140, 150, 160, those are not giving you symptoms day in and day out. Okay. What they do over time when it's not controlled is they lead to all those other conditions that we want to avoid: heart attack and stroke, dementia related vascular brain injury, chronic kidney disease. So hypertension, listen, this is so key for you to think, and I want you to leave with a whole bunch of hope tonight. This is a modifiable risk factor. And the only way we can make a change and get it lower and on target is if you know what the blood pressure is. So tonight, in a few moments, we're actually going to walk together through how to accurately measure your blood pressure, how we make the diagnosis, what the lifestyle factors are that we can use to treat first, and what medications are safe and available to use to get you to the finish line as far as a blood pressure target is concerned. So decoding the mechanics of your daily numbers. If you imagine a pipe and pump system, I mentioned earlier that high blood pressure is related to the pressure inside the vessel. That's the pipe. When your heart is beating, that is what the pressure in the system creates the systolic blood pressure. That's the top number. When your heart or the pump is relaxing, the pressure in the pipes or the system. The bottom number is the diastolic blood pressure. I want you to take a look at the circadian rhythm of our blood pressure, which is actually reflected on this slide as well. So there is a natural, and the reason we ask you to take your blood pressure at different times of the day, this is an important take-home point, is that your blood pressure is different at different times of the day. It's, yes, triggered by stress, exercise, caffeine, by your sleep, but there's also a natural circadian rhythm that underflows all of that. Okay. So from midnight to 5 a.m., if you want to get the best readings to share with your doctor, take your blood pressure between midnight and 5 a.m. That is called the nocturnal dip. Between 6 and 10 a.m., this is the morning surge. Blood pressure is highest in the morning, typically between 6 and 10 a.m. That is also why the majority of a disproportionate number of heart attacks actually happen in the morning, is because of this blood pressure surge. Mid-afternoon, there is a peak and a plateau, and then in the evening, the blood pressure will gradually come down. And so don't put too much stock in one reading. We have to look at the context of that reading, and getting representative readings over time is really, really important. This is the slide that you're going to, I hope, take a picture in your mind and remember, because this, for us medical practitioners, for us as patients, for all of us in Canada, this is the biggest change with the new hypertension guidelines. Historically, if your blood pressure in 2024 was 140 over 90, I would have called you and said, way to go, you're on target. If it's 140 over 90 in 2026, I'm calling you to say we've got some work to do. Now, why is that? Did you change? Nope. The meaning of the numbers didn't change. Not really. The evidence changed. That is what has gone into the new clinical practice guidelines from Hypertension Canada. This new threshold for diagnosis, we're going to walk through how to measure it properly with a validated device, but this shift is really aiming to simplify care and improve long-term control, shifting focus to early lifestyle interventions. The history, I've been practicing long enough to remember a lot of different iterations of hypertension guidelines, right? There have probably been 5 or 6 major ones in the last 25 years. Now, that doesn't mean any of them were wrong along the way. It means that there are subtle shifts in the guidelines and the recommendations in each of those iterations, and they're all taking us closer towards what we hope is improved survival based on the evidence that we have at hand. And today, in 2026, the best evidence we have is that we are all shooting for a target of less than 130 over 80. I should emphasize, especially when we talk about the treatment advice, while these targets are the same across the board, the clinical practice guidelines that we're talking about tonight do not deal with individuals who are pregnant or breastfeeding with high blood pressure. So this is a really important concept that I tried to introduce a little bit at the beginning. Guidelines are a map, and they're not a strict mandate. While 130 over 80 is the new baseline that we should all be targeting, it's not a strict mandate for everybody. Targets must be personalized based on your unique health profile, and your clinician or whoever your trusted person is, I hope it's primary care of some type, and I hope you have access to that, will consider factors like frailty and fall risk, blood pressure drops when you change position, which is orthostasis, and other comorbid conditions that you may have before we just blindly or randomly apply a guideline to you. You may not even feel like you're stressed, but there's something happening with your autonomic nervous system that is constricting those tubes, those vessels, and making your blood pressure go up. White coat hypertension is where your readings are only elevated at the doctor's office. The 2025 guidelines that we're talking about tonight strongly emphasize confirming whatever reading you get in the office out of office. So this is what we're calling a truer baseline to ensure accurate diagnosis. So taking a blood pressure reading in your calm home setting and daily readings for a couple weeks is often far more informative than a single isolated stressful office visit. I think most people would agree with that. Now, we did receive a large number of questions in advance of this talk tonight from people who seem to be falling into this category. Their readings are dramatically different at home versus at the doctor's office. So what do we do when this happens? Well, this isn't about choosing which number we like better. It's about understanding what each measurement is telling us and what the context of the measurement is about the whole person. So in reality, we're trying to integrate multiple sources of readings, not replace one with the other. So what I'm saying here doesn't mean the office visits, the readings you get at the office are not useful. They are. They need to be taken into context with other readings that you're getting at home. And this is another major takeaway from the new guidelines. It emphasizes a standard approach, which I'm going to show you on the next slide about how to measure your blood pressure, and it favors out of office confirmation of the blood pressure to get a diagnosis. So I joked at the beginning that I hoped you were all sitting in a sitting position with your back supported, with your feet flat on the ground, legs not crossed. This is essential, right? That checklist down the left-hand side is really, really important. Proper preparation. Don't have a smoke and drink a coffee 10 minutes before you're checking your blood pressure. That is bound to give you an elevated reading. Don't do exercise 30 minutes before you want to check a reading either, because that's going to artificially elevate it. The appropriate equipment is important, and I just want to emphasize here that there are validated automated blood pressure devices that are sold at any drugstore. They're sold on Amazon. There is, on the next slide, I'm going to show you an example of a device that has the Hypertension Canada logo on it, which anything that you're buying and trusting at home should have that logo on it. Cuff size matters, okay? So there's a wide range of cuff sizes, and what I should say is your arm size matters, right? And so not every cuff fits every arm properly. And if you're using a cuff that is too small for your arm, it will artificially elevate your blood pressure as well, okay? So that is the picture I want you to remember about optimal blood pressure measuring technique. And most machines that you purchase, or those that are at a pharmacy, if you're using those, even doctors' offices now, have this picture in them to demonstrate how we want people sitting and what prep we want for you to have. So here, as promised, is an example of one of the right tools for accurate tracking. I don't care what brand this is. I just care that it has the Hypertension Canada recommended logo on it. And I also care that it's not a wrist or a finger device. They do not tend to be as accurate. This should be something that will fit on your upper arm when you're sitting comfortably. So we're going to dive into, this is where we get into a bit of the science, right? These are the algorithms that the doctors have to understand and be able to walk their patients through and put these into terms that patients are going to understand, okay? So this is the algorithm for the proper diagnosis. So at the top of this particular slide, you can see that hypertension is suspected. Okay, so you take a reading like our patient Maria. She took a reading in the pharmacy. Ooh, 140 over 90 or 145 over 90. She's thinking, she's read the new guidelines. She saw a brochure. She talked to her. She knows that value is a little bit outside of where she wants it to be. So she books an appointment with her doctor. She comes into the office. We check Maria's blood pressure again. Now, the question is, and look at that question mark, is the blood pressure greater than or equal to 130 over 80? If no, we can give Maria a high five and a sticker and ask her to book back in 3 months and we'll check it again for her. No hypertension. If the reading in the office now is confirming what she got in another setting in the pharmacy or at home, and her out of office blood pressure, so the office visit has a reading over 130 over 80. Now, I'm not just going to say, oh, that's one reading, you've got hypertension. I'm going to give her a homework assignment. I'm going to ask her to do some readings at home if she has access to a cuff, or a pharmacy if she doesn't. And if her out of office blood pressure measurements are not above 130 on 80, then again, we're calling that white coat hypertension, right? She only had an elevated BP in my office. That first one in the pharmacy, I was suspected it might have been a one-off. She went away and did 2 weeks worth of readings down here and no high blood pressure. So white coat hypertension. And here's where it gets interested, and here's where we're going to follow Maria's story, because she does in fact have readings at home that are greater than 130/80 consistently, we now have a pretty solid diagnosis of hypertension. It's taken time, multiple readings, an automated cuff, and we're going to provide her with some education about how we can best treat this. So, this is now the algorithm for how to treat hypertension, and this is based on the CMAJ publication in 2025 for primary care providers like myself, again, not intended for use during pregnancy. So once our diagnosis is confirmed, our goal is to reach that systolic blood pressure target, that top number. We want it less than 130, and this is in order to protect our long-term health. This treatment blueprint that you're looking at goes potentially down two different pathways, okay? So I'm going to start with the pathway on the right. If your blood pressure readings are 130 to 139, so you're above the target, and you don't have any other risk factors for heart disease. So those would include diabetes, smoking, high cholesterol, obesity. If you have a low overall risk for cardiovascular disease, and your family physician can actually calculate that risk for you based on all your numbers, then the recommendation is healthy lifestyle changes. There's a picture of an apple. We're going to dive down further into what those healthy lifestyle changes look like in a couple moments. And we're going to reassess you in 3 to 6 months. Now, at the reassessment, we have, again, the same decision point. We're aiming for that same target. Is your systolic blood pressure less than 130 and you still have low cardiovascular disease risk? You go right down to the bottom of this, emphasize healthy lifestyle changes, and reassess every 6 to 12 months. But if your blood pressure on the reassessment is greater than 140/90, or it's 130 to 139 and you have high cardiovascular disease risk, we have to go down the left-hand column. So this is where now, again, 140/90 consistently, or you have 130 to 139 with multiple risk factors like smoking, high cholesterol, diabetes, obesity. These are individuals that out of the gate, we recommend healthy lifestyle changes, and there are many of them that can help. And we walk you down the options for pharmacotherapy. And we're going to get to that in a moment. So shelve that. We're going to come back to this after we talk about really what I would consider the most important part of the talk tonight. What can you do to take control of your own health? Here are some key lifestyle changes that you can make to improve your blood pressure now, starting after this talk tonight. And I actually just want to emphasize, so I talk to patients a lot about how we can get changes to stick. It's one of the hardest things in life to do, right? A lifestyle intervention is going to stick if your heart and your brain make a decision and have agreed that whatever action you're talking about is added to your list of non-negotiables in your life. I'll give you an example. Picking up my kids after school is a non-negotiable. I have to do it, whether I want to or not. I got to be there. Brushing my teeth, having a shower, sleeping. These are non-negotiables in your life. Are you prepared to make a change in your life that can make any of these changes on this slide a non-negotiable? These are part of your DNA and your fabric. You have to get there with both your brain and with your heart. You got to be behind, and it's the hardest thing that you're ever going to do. I want to make a quick comment about nutrition and sodium before we move on, because this is one of the biggest things you hear. Eliminate sodium, cut down sodium, and there's a reason you hear that, because it can have an impact on lowering your systolic blood pressure. The DASH diet, which is dietary approaches to stop hypertension, that is an acronym, is the most commonly recommended dietary approach for specifically targeting the disease and the risk factor called hypertension, right? It focuses on increasing the number of fruits and vegetables that you're taking. It focuses on reducing daily sodium intake to, there's a range, but less than 2,000 milligrams. It involves choosing whole grains rather than refined grains. It involves healthy fats like olive oils, low fat dairy products. Okay. When you go down the list of the DASH diet, if it sounds familiar to many of you, it will if you've historically picked up the Mediterranean diet. They're not identical, but the Mediterranean diet is still the one I recommend for all of my adult patients to follow for overall risk factor benefit, for overall not just hypertension, but reduction in risk for dementia, for cardiovascular disease writ large. The main difference is the DASH diet has a singular focus on hypertension and reducing salt, along with increasing vegetables. The Mediterranean diet, I always remind patients it has more flavor and it focuses more on healthy fats. So things to consider, things that you can change tonight. Physical activity recommendations, 150 minutes every week of sustained physical activity should be a minimum target that you're going for if you want to have a positive impact on your blood pressure and your cardiovascular risk. Moderation of alcohol means probably less than you're consuming now, and smoking means not at all. So lifestyle is something I spend a lot of time counseling my patients about, and something I'm really hoping people will take away from even one of these boxes. Pick one of them and make a change that's going to last for 6 months, and your blood pressure will drop by 5 or 10 points. That's the goal. And it costs you nothing to do it. So there are situations where lifestyle changes alone are not enough to bring down your readings to 140 on 90. So this is where you need to work closely with your medical team to talk about what the other options are. And starting medication, I want to emphasize, is not a failure. It is a protective tool. Working closely with the clinician ensures high adherence and getting on top of any side effects that you might experience. This is just a very brief interlude slide meant to remind everybody that it's going to be okay. All right. Hypertension diagnosis is not a personal shortcoming. It is manageable, it's modifiable, but it is, in fact, a lifelong condition. With the right combination of lifestyle, daily habits, and medicine if needed to get to that target of less than 130, blood pressure usually will improve gradually. This is a treatable condition. Treatment plans have to be individualized, and medication adjustments are common and they are normal. And our goal is to protect those blood vessels, not to be perfect. There are 4 major classes of blood pressure medications that you will see. They're broken down into clusters here, though, of how they impact your vascular system. And let's talk about these as when my patients complain about taking pills, I empathize with them. I don't like prescribing pills, but what I like even less is my patients having strokes and heart attacks and dementia earlier than it needed to happen are preventable conditions if we can get on board with the treatment. So nobody wants to take medications, but they are highly specific biological tools that are designed to fix specific parts of your cardiovascular system. I am not randomly reaching into a bin of pills and saying, let's try this one. The choices we are making, or we should be making, are based on the evidence that is in front of us. And the best evidence we have are that these classes of drugs actually work and are safe over the long term. I'll talk a little bit more about each of these, but ACE inhibitors, ARB is angiotensin receptor blocker, and calcium channel blockers, they all work by relaxing the pipes. Okay, they widen the pipes, they relax the smooth muscle in the arteries. Beta blockers, we do not use as first, second, or third line anymore for blood pressure control unless you have a history of congestive heart failure, then you would likely be on one. And diuretics, we commonly use, and they help the body flush out excess sodium. If only pharmacists could find a way to clearly label bottles so that humans could understand what writing was on it, and so that the font size was big enough that you'd actually be able to read it. So the names of the drugs are on the far right. The class of the drug is on the far left, and the nickname and how it works is in the middle. So diuretics reduce fluid, ACE inhibitors and ARBs, they relax the pipes. Calcium channel blockers provide some tension relief in the arteries as well. And beta blockers slow down the heart and reduce the work of the heart. That is how they work. And there's common examples of names there that I won't go into too much. So we're going to take a deeper dive into the part that's shaded gray on this treatment algorithm. And so we're going to zoom in here and say, well, what might your doctor be prescribing for you right now? Listen, I should emphasize that like the number of people on this call and watching this presentation, there are likely a number of you that are clearly have been diagnosed with high blood pressure. may have had this conversation with your family physician or another provider many times to try and get a better understanding of how the diagnosis is made and how we approach treatment. And some of you might be on medications right now, multiple medications to try and get your blood pressure under control. This is a really new simplified approach to managing blood pressure that needs medications to help get to that target of 130 or less. And while this is a new approach, if you are currently on medications and reaching target, do not go in and ask your doctor to change your medications so it matches exactly what's on this algorithm. This algorithm is an example of how a newly diagnosed person with high blood pressure could and should walk through the steps. So, step one, and this is a big change. This is actually a big change for us as providers. The idea of starting with a combined drug, a low dose of a combination drug. They've used options here that are an ARB, an angiotensin receptor blocker named irbesartan, and hydrochlorothiazide, and they're suggesting start with, if you need a medication, half of this tablet, and then check blood pressure again in 1 to 3 months. Check readings at home at multiple times of the day with an automated cuff. If you're still not on target of 130 over 80, and we want to be below that target, step two is to simply take the full tablet now. So you're increasing the dose. It's two different medications that are in one pill. They work synergistically together, they're additive, they have different mechanisms, as I showed you on a previous slide, and they do result in pretty significant reduction in benefit. If you still don't have blood pressure controlled with a full dose of that combined agent, the newest guideline recommends adding a calcium channel blocker called amlodipine at a dose of 5 milligrams that can be increased to 10. And step four, you've got one of two options. Either add spironolactone, which is a new development for us in primary care. It's not a new drug. We use it for other reasons, but to add it to the hypertension algorithm is fairly new. Or at this point, most of us would be referring to a specialist, either a cardiologist, an internist, or a nephrologist to investigate other possible causes for high blood pressure. So I want to highlight that right now. What we've been talking about exclusively is blood pressure related to aging, which is essential hypertension. So that's the standard damage and wear and tear to the inside of the blood vessel. But there are clusters of causes of what we call secondary hypertension, which is where the high numbers you're seeing, first of all, they tend to come on very suddenly and they are a symptom of an underlying medical condition elsewhere in the body. The most common examples are chronic kidney disease. There are hormonal causes that have fairly complex names. So, adrenaline releasing tumors called pheochromocytomas, Cushing's syndrome, Conn syndrome, all things that make the hormone levels in your body wonky. These are rare conditions, but they sometimes explain why blood pressure is not being treated adequately and should be investigated if you get to step four of the algorithm I just showed you and you're not having any success or improvement. So two interlocking gears driving your long-term health, right? Lifestyle, we talked about, and medication. It's not either or. They're not competing against each other. They're synergistic tools, and the goal of treatment is really not to pass a specific test for a specific number, but to continue to lower your long-term vascular risk. So if you can lower your numbers so your blood pressure is consistently less than 130 on 80 with just lifestyle modifications, of course that's our goal. But if you're running higher than that for weeks and months and years at a time, damage is happening to the inside of your arteries. And we really need to use those biologic tools that we call blood pressure medications to get you on target safely and effectively. So we're going to close with the case of Maria, back to Maria. And thankfully, she did not ignore her pharmacy reading, but and she also didn't use it as the sole source of her information. She went to see her doctor. She measured at home for 2 weeks. And after that initial blood pressure reading of 140 on 95, she tried some lifestyle improvement after getting guidance from her primary care provider. And again, that goal of less than 130 on 80, in her case, was not achieved after the lifestyle interventions for 3 to 6 months. And so we started a half a dose of irbesartan and hydrochlorothiazide, which then did get her onto target. Last slide, your blueprint for vascular aging, just to summarize what we've gone over tonight. And we've covered an awful lot of ground. I appreciate you sticking with me The pace might be a little bit much in terms of how heavy the material is for a short period of time. I hope I've been able to summarize it well, but this slide will attempt to do that for us. Accurate measurements, really important. An automated cuff is essential, and repeat measurements at different times of the day at your home or at a pharmacy. Implementing daily healthy habits. If you take nothing away from this talk tonight, pick a lifestyle improvement you want to make and go out and start making it tonight or tomorrow morning if you want to sleep on it. Then please partner with your clinician. If you're seeing readings that don't look right, they're probably worth some attention. And I hope, above all else, that everybody took something away from this talk. I really appreciate it. Looking forward to the Q&A, Dr. Levinson. Thanks again for the invite.
Well, thank you so much, Doug. That was tremendous. And we had some people saying, not a question, a compliment, super informative presentation and easy to understand. So I think that gives you an idea of how informative it was. Let's dive right in there. We do have quite a lot of pre-submitted questions. Many of them were incorporated into the presentation, but we have some others. And I just want to reiterate the session is for educational purposes, not a substitute for advice from your own healthcare professionals. And as you pointed out, Doug, that it is a very personalized approach. There may be people with different medical conditions where the target needs to be adapted. So the biggest theme right out of the gate was probably my numbers are different everywhere. And so you covered a few of these, but how much variability is normal? Now, one of the people submitted a question, said they have an approved blood pressure monitor. They took the 1 minute gap blood pressure reading, the first reading 122 over 65. So congratulations, not hypertensive. Second reading 112 over 65. Why would they even diverge that much in a minute? And I guess that's similar to some of the other questions around what do I do with when readings seem disparate?
Yeah, that's a really great question. I'll start with one tip that I give my patients. It is very, very common, not all the time, but the most common scenario is the first reading you take is usually a bit artificially high. I usually tell patients to throw it out. Throw out the first one. Don't even include it in your average. And in fact, the machines that we use, the automated cuffs that we use in our office are called BP True machines. I don't recommend you buy them. They're expensive, but they do 6 readings over 6 or 7 minutes. So there's a minute break in between each. But 6 readings, the first one is discarded, and the computer doesn't even factor it into the average. And we take the average of 5 readings to get the best idea of what's going on. So that's my first comment, is that some variability is normal. Literally, this is the physiological variable in our human bodies that fluctuates the most throughout the day from minute to minute. In fact, beat to beat, the blood pressure is different. There should be the variability of 3 to 5 millimeters of mercury that we can accept. But if you're getting double-digit variability between readings, go back to the slide tonight about technique. Make sure your technique is
Okay.
proper, your body position, no movement, and then double check it. You can take your machine in and validate it with your family doctor as well. I had somebody this week literally who was getting readings at home 30 points higher than they got here. Like, so they were booking in a crisis, and we were doing, it was the opposite of white coat hypertension. And we were able to kind of just, hey, can you bring your machine in next week and we'll check against that? Because there's clearly something not right here.
You mentioned if the cuff is too small, that may affect the readings.
Yeah.
One of the questions that just came in was, does a cuff that is too big also give an incorrect reading?
Yes, it will. Listen, the measurements matter. I'll give you a quick tip about how to measure your own arm. So if you go around the middle of your upper arm and your arm is less than 34 centimeters, that's a regular cuff. The one that comes with the machine, the one that's already plugged into it. If it's more than 34 centimeters, you should be grabbing a large cuff to make sure the readings are accurate. And more than 45 centimeters, we actually have a category called a bariatric cuff or a thigh cuff that we would recommend using, because yes, it does cause a lot of variability if the cuff size isn't accurate. Now there's a good range with all those sizes, right? Within 10 centimeters. So it doesn't have to be exactly personalized to you, but some of the most common thing we see is people are using cuffs that are too small at home.
One of the questions was the focus in the guidelines on referencing the systolic reading, the upper number, the 130, and not the as much emphasis anymore on combined upper and lower, systolic and diastolic.
Yeah.
What's your take on that?
Yeah, there's the pendulum has swung. I alluded to the fact that there were guidelines back in 2008 and the early 2010s that did place a bit more of an emphasis on diastolic. And I just think the morbidity and mortality data from longer term, larger studies hasn't borne out to say that it's as important. It's not a nothing, but the pressure in your heart when it's relaxing, which is the diastolic pressure, doesn't, even if it's high, even if it's 90, even if it's 95, isn't contributing as much to damage inside those arteries as we know that big pulse of systolic push does when the pump is contracting.
Great. We had some questions around medication hesitancy and side effects. So, medication questions were actually one of the largest category, and especially concerns about side effects. And so, can people ever reduce or stop blood pressure medication? And how do you balance treatment with dizziness or risk of falling?
Yeah, there's a lot of good stuff in there. And I don't blame anyone for having lots of questions about medications, for any chronic condition. If a doctor told me today I had to take this pill for the rest of my life, I would need some pretty strong justification for it. And I'm a prescriber of these medications, right? It's not a part of my habit. But again, we have to weigh risks and benefits. So if I can reduce my risk of having a heart attack in the next 10 years by 20%, and that's what we're talking about, getting these numbers on target, that's a framing that I can get behind. I can take this pill every day now with my vitamin D and I call it a day, and I'm going to accept that I'm getting some benefit from this as an individual. But the side effects are potentially a big deterrent. People have a lot of you. So one of the viewers asked questions about the side effects. Every class of drug that I put up there have some side effects. I'll run briefly through the common ones. ACE inhibitors. If you've been on an angiotensin converting enzyme inhibitor, anything that ends in a prill, you have a 1 in 6 chance of having a chronic dry cough. That's enough of a reason for me to stop taking that. And that's the number one reason we stop prescribing them. Now, they have amazing benefit from your heart and your kidneys and your blood pressure control. But alternatively, increasingly, ARBs have become the better tolerated class, the angiotensin receptor blockers. So anything that ends in an artin, those are the ones that tend to have better side effect profiles and specifically no cough. Diuretics, we see more abnormalities in electrolytes, right? So thiazide diuretics are going to cause a drop in potassium levels potentially. That's less than 5% of people, and that's why we do blood work once after we start you on it. And the biggest thing with amlodipine or calcium channel blockers is swelling, which again can be well controlled by just adjusting the dose or switching to another agent. But overall, these are classes of drugs that are pretty well tolerated and fairly effective. Hesitancy, what I would encourage to summarize, just sit down and book time and have the conversation with a provider that you trust and let them know what you've done for your lifestyle, what your values, what your goals are for your health. And when we factor all that in, we'll try and come to a better conclusion for you.
We have another question that what can be done if you have tried many blood pressure pills but still have uncontrolled blood pressure or hypertension?
Yeah, so if you've tried them and you're still on them, if you're on three different agents and you're from different classes, and your blood pressure is not well controlled. And this is not much of a change with the new guidelines. This has always been our practice for many years. The recommendation would be to start what we call a workup for secondary hypertension. And that usually initiates with the lowest hanging fruit, which is kidney disease. So we would do a renal ultrasound and check blood work to make sure your kidney function was good. If that's all normal, and you're on three different agents, I mean, now I would start spironolactone as a fourth agent and put a referral in place to either a cardiologist or a nephrologist to get an opinion. Because that's when you would need to start looking at, well, why is it still up? If we're doing everything right, the doses are correct, your adherence is good, and you're taking them every day, and we're still not in control, we just need to make sure that some of those other less common causes have been eliminated.
We had some questions around the targets for older adults after the age of 80 and whether there are any kind of like how low is too low. So, should the targets change at some point? Are aggressive targets always appropriate for older adults? And there were some other questions around when is the diastolic blood pressure too low? So, systolic and diastolic.
So the answer for when either of your blood pressures is too low is typically, and I mean this, when you're having symptoms, that's a clear, and the symptoms are going to be what we call orthostatic drops, or like drops in blood pressure that are causing dizziness. So symptomatic blood pressures that are low, you need to go in and see your doctor and make some adjustments. You might be on too much medication. There might be other medications that are interacting with what you're taking. Your first question was, what do we do as we age if we're worried about the risk of, and the biggest risk that I deal with day in and day out in my practice is the risk of falling on these
Mm.
medications, right? So with the blood pressure drops, we don't get enough oxygen to the brain, I get dizzy, I fall. Well, now we've created a much bigger problem for an 85-year-old than we were solving by treating the blood pressure to the perfect target. So I kind of buried the lead for this whole talk. I actually spend most of my practice de-prescribing these medications for my older adult patients. Their life.
Yeah.
What is the goal of their care? What's their level of frailty or function? And what other medications are they on? And what other diseases do they have? And there does come a time where it makes good sense to start gradually coming off these, but please do it with somebody who can help you do it safely.
Several questions related to particular lifestyle factors, and I'll just start with two of them. Which lifestyle change has the biggest impact, and can walking alone meaningfully lower blood pressure?
These are great questions. I spend a lot of my spare time reading about this and wanting to learn more because I always want to know what the one answer is going to be to give us the secret. So,
Yeah, if I have to do any lifestyle change but give up alcohol, which one would
right.
it
But this is the answer has to be brief because I know we're running short on time, but it has to be nuanced because it depends on what current risk factors you're carrying right now. So if you're already exercising 150 minutes a week, eating a DASH diet, getting great sleep, and you smoke, well, guess what? The number one risk factor that's going to improve your profile is stopping smoking. But all that aside, the evidence would say that the number one, reducing salt, if you want to take that away, and if you're carrying extra weight, losing weight through exercise and healthy eating. Those would be the two that would have the most sustainable and notable reductions in systolic blood pressure. All the other ones help as well, but battling obesity and eliminating salt down to those targets that I shared earlier would be where I hit. But again, if you're smoking and drinking too much, you've got to eliminate the cigarettes and moderate your alcohol, the factor as well.
Well, that was fantastic. I am conscious of the time as well. There are a lot of other questions in there. If I could ask you to stop, I want to share a couple of resources. So, Dr. Oliver has spoken about the hypertension guidelines. There is an excellent site, hypertension.ca/public, will take you to this public facing page from Hypertension Canada, a great organization that helped produce the guidelines and does a lot for educating professionals and the public on that. We have quite a lot of content on the McMaster Optimal Aging portal related to hypertension, high blood pressure, and just about any other topic related to healthy aging. So if you aren't familiar with the portal, it's a great source for evidence-based content on how you can age. You can get a free weekly email in your inbox because the content on the portal is continually updated. So you'll get our latest blog posts, you'll get announcements related to webinars like the one tonight. There's a range of different posts, including video posts on various topics. And there's also multimedia e-learning lessons that are usually a little bit more in depth, a bit longer on various topics related to brain health, mobility, exercise, a wide range of topics. There's also micro learning, which are basically shorter courses of email based learning, usually a weekly email on a topic. Again, all of this is provided free through the portal. We do record these webinars, and they are also available through both the Alumni Association's YouTube channel, and you'll get an email if you registered for the talk tonight. And they're also available through the portal's channel as well, if you like that. So, on behalf of Dr. Oliver and our McMaster Optimal Aging portal and the Alumni Association. Thank you so much for joining us, and thank you, Dr. Oliver, for a fantastic talk tonight.